The amount of blood the heart pumps through the circulatory system in a minute is called cardiac output, which is equal to stroke volume, the amount of blood put out by the left ventricle of the heart multiplied by heart rate in 1 minute. Stroke volume is determined by preload, the volume and pressure of blood in the ventricle at the end of diastole, contractility, and afterload, the volume and pressure of blood in the ventricle during systole. For example, normally, stroke volume is nearly 75 milliliter with each contraction, and consider that heart rate is 60 beats per minute, then cardiac output is 4,500 milliliter per minute or 4.5 liter per minute. A normal adult has a cardiac output of 4.7 liters of blood per minute, and the percentage of how much blood in the left ventricle pumps out with each contraction is called ejection fraction, which is equal to stroke volume divided by end diastolic volume, total volume of blood in the left ventricle before contraction, which is normally nearly 110 milliliter. So this is equal to an ejection fraction of 68%, means that 68% of the total amount of blood in the left ventricle is pushed out with each heartbeat, and normal is between 50 to 70%. Heart failure describes the clinical syndrome that develops when the heart cannot maintain an adequate cardiac output or can do so only at the expense of an elevated filling pressure. Mostly, the primary abnormality is impairment of ventricular function leading to fall in cardiac output. This activates counter-regulatory neurohumoral mechanisms that, in normal physiological circumstances, would support cardiac function, but in the setting of impaired ventricular function can lead to deleterious increase in both afterload and preload. Stimulation of renin-angiotensin-aldosterone system leads to vasoconstriction, salt and water retention, and sympathetic nervous system activation. Activation of the sympathetic nervous system may initially maintain cardiac output through an increase in myocardial contractility, heart rate, and peripheral vasoconstriction. However, prolonged sympathetic stimulation leads to cardiac myocyte apoptosis, hypertrophy, and focal myocardial necrosis. In most instances, patients remain asymptomatic or minimally symptomatic after the initial decline in pumping capacity of the heart, or develop symptoms only after the dysfunction has been present for some time, and that's why the term heart failure is preferred over the older term congestive heart failure. Heart failure can be caused by systolic dysfunction, which also called heart failure with reduced ejection fraction, which is inability of the ventricle to contract normally, resulting in decreasing cardiac output with ejection fraction EF of less than 40%. When oxygen supply to a part of the myocardium is insufficient to meet its metabolic needs due to ischemia or plaque formation in the coronary artery, which is cause cardiomyocyte hypoxia, leading to ventricular dysfunction, and ventricles can't contract normally, and probably heart failure, and this is the reason why ischemia is one of the main leading cause of heart failure. Second, MI. After MI, cardiac contractility is impaired and neurohumoral activation causes hypertrophy of non-infarcted segments, with thinning, dilatation, and expansion of the infarcted segment. Third, dilated cardiomyopathy, which is a progressive disease of heart muscle that's characterized by ventricular chamber enlargement. But heart failure can be due to poor ventricular filling and high filling pressure caused by abnormal ventricular relaxation or diastolic dysfunction, which is also called heart failure with preserved ejection fraction. Is caused by a stiff non-compliant ventricle and is commonly found in patients with left ventricular hypertrophy due to hypertension or constrictive pericarditis and restrictive cardiomyopathy. With normal ejection fraction more than 50%, this is because the amount of blood that enters left ventricle is already decreased. For example, If the end diastolic volume is decreased from 110 to 70 milliliters and stroke volume from 75 to 40 milliliter, then the ejection fraction is equal to 57%, and this is normal. Often, systolic and diastolic dysfunction coexist, particularly in patients with coronary artery disease. Estimates vary, but about 50% of patients with heart failure have heart failure with preserved ejection fraction. The prevalence increases with age and in patients with diabetes. And this systolic and diastolic dysfunction may occur in the left or right side. Left-sided heart failure is more common, which there is a reduction in the left ventricular output and increase in the left atrial or pulmonary venous pressure. An acute increase in left atrial pressure causes pulmonary congestion or pulmonary edema, with a sudden onset of dyspnea at rest that rapidly progresses to acute respiratory distress and orthopnea, which is defined as dyspnea occurring in the recumbent position. The patient appears agitated, pale, the peripheries are cool to touch, and the pulse is rapid. The blood pressure is usually high because of sympathetic nervous system activation, but may be normal or low if the patient is in cardiogenic shock. In examination of patients with pulmonary edema, crackles, rales may be heard widely over both lung fields and may be accompanied by expiratory wheezing. Crackles occur if the small air sacs in the lungs fill with fluid and there's any air movement in the sacs. A more gradual increase in left atrial pressure, as occurs with mitral stenosis, leads to reflex pulmonary vasoconstriction, which protects the patient from pulmonary edema at the cost of increasing pulmonary hypertension, fatigue, and weight loss or cardiac cachexia. Paroxysmal nocturnal dyspnea (PND) refers to acute episodes of severe shortness of breath and coughing that generally occur at night and awaken the patient from sleep. In the right-sided heart failure, there is a reduction in right ventricular output for any given right atrial pressure. Causes of isolated right heart failure include chronic lung disease, cor multiple pulmonary emboli, and pulmonary valvular stenosis, and may be caused by left ventricular hypertrophy or left-sided heart failure. Peripheral edema up to thigh, sacrum, abdominal wall, ascites, nausea, anorexia as main symptoms of right heart failure. In examination, hepatomegaly is an important sign in patients with heart failure. In case of biventricular heart failure, failure of the left and right heart develop because of the disease process, such as dilated cardiomyopathy or ischemic heart disease, affects both ventricles. The cardinal symptoms of heart failure are fatigue and shortness of breath. In the early stage of heart failure, dyspnea is observed only during exertion. However, as the disease progresses, dyspnea occurs with less strenuous activity. Heart failure should be distinguished from first conditions in which there is circulatory congestion secondary to abnormal salt and water retention, but in which there is no disturbance of cardiac structure or function, for example renal failure, and non-cardiac causes of pulmonary edema. In most patients who present with classic signs and symptoms of heart failure, the diagnosis is relatively straightforward. However, even experienced clinicians have difficulty differentiating the dyspnea that arises from cardiac and pulmonary causes. In this regard, non-invasive cardiac imaging, echo, which is the key investigation, it may indicate the cause and can confirm the presence or absence of left ventricular dysfunction. ECG, or biomarkers. Circulating levels of natriuretic peptides are useful and important adjunctive tool in the diagnosis of patients with heart failure. In the management, acute heart failure is a medical emergency, but in chronic heart failure, the patient should stop smoking and alcohol, eat less salt, and the cause should be treated. For example, if there is dysrhythmia or valve disease, treat exacerbating factors like anemia, thyroid disease, infection. Drugs that reduce preload are appropriate in patients with high-end diastolic filling, like diuretics, and those that reduce afterload or increase myocardial contractility, like ACE inhibitors and beta blockers.